So let's continue. So minimal change disease. The most important thing when you get an analytical question like that is what is the diagnosis? Nephrotic syndrome. What's the most likely cause? Minimal change disease. And then what are the features of minimal change disease? This is something which is extremely important for you to remember, is that on light microscopy there is absolutely no abnormality. And also there are no immune complexes. Okay. So this is one of the diseases which is extremely important to do electron microscopy, because on light microscopy also we will not see anything wrong, and on immunofluorescence also we will not see any immune deposits. The only thing which will be seen is on electron microscopy we look for effacement of foot processes of the podocytes or the visceral epithelial cells. Okay, so that is the important thing about minimal change disease. You have to remember that it is normal on light microscopy, no immune deposits on immunofluorescence, and there is diffuse effacement of foot processes on electron microscopy. But one thing is there's a dramatic response to steroids. Focal segmental glomerulosclerosis is usually seen in adults with nephrotic syndrome. This is basically, if you look at this glomerulus, part of the glomerulus, if you look at the lower half, looks completely normal. Lumen is patent, mesenterium is okay, not too many cells. But in this area, you can see that the mesenterium appears very dark pink because it is sclerosed. Okay, so there are some sclerotic areas. And because it is just part of the glomerulus, so we call it segmental. Okay, so focal segmental glomerulosclerosis is a cause of nephrotic syndrome in an adult. Membranous nephropathy is when the deposits are just here at the basement membrane. So you will find, this is electron microscopy, the basement membrane is very thick, and here on light microscopy, if we do a stain which is a silver stain, we can see that the basement membrane is extremely thick. So this is the feature, and on of course on immunofluorescence we will look for deposits along the basement membrane. Okay, so remember, if nowadays I'm noticing in NEET also they give you pictures like this and they ask you to interpret. Okay, MCQs, but they put pictures like this. So remember, in acute post-streptococcal glomerulonephritis, you will have a glomerulus looking like this on immunofluorescence. Okay, so that is why one picture is not enough. This is not a acute post-streptococcal. In acute post-streptococcal, the lumen is not seen. Everything is very hypercellular. Okay, so if you have a very hypercellular glomerulus with this picture and the history fitting with a child having a 2 weeks history of fever and now hematuria and hypertension, you know that you are dealing with an acute post-streptococcal. But if you get a picture like this which has actually lumen is patent but the basement membrane is thickened, okay, this is all thickened basement membrane, the glomerulus looks almost as if it's normal, but the immunofluorescent picture looks bumpy, dumpy like this. And this is membranous nephropathy, which is again a disease which is usually, it causes nephrotic syndrome, okay? And most of the time it is a secondary cause of nephrotic syndrome. That means these kind of patients have a primary disease like they're suffering from some autoimmune disorder, rheumatoid arthritis, systemic lupus erythematosus. So they may have a primary disease, and membranous nephropathy may be a secondary change to that primary disease. So the treatment will be based on the primary disease. This is Membranous Proliferative glomerulonephritis. Here you can see that the lumen is totally blocked. Okay, it is cellular. The whole glomerulus is enlarged. And one thing which you should notice here on histopathology is that it looks like petals of a flower. Okay, so this is known as lobular accentuation, as if it is divided into lobes. This is the feature of Membranous Proliferative glomerulonephritis. This is known as lobular accentuation. And another thing is, this is a stain which is a silver stain. That's why it's looking black here. You can see that the basement membrane is thickened at some places, and in some places the basement membrane is divided into two. Okay, that is known as a tram track appearance. All these are objective questions which can come. Tram track appearance, lobular accentuation are features of Membranous Proliferative glomerulonephritis. Please read up all of these because I'm telling you just the basic stuff which can come as questions. IgA nephropathy, it is basically, if you look at this glomerulus, the lumen is absolutely patent. There's nothing wrong with the capillaries. However, you can see this pink area here and many, many nuclei. That means the mesenterium is the one which is undergoing hypercellularity. And when you do an immunofluorescence, the IgA deposit, this is a IgA deposits in the mesenterium, and they look like very huge deposits in the mesenterium. Okay, so this is a classical picture of IgA nephropathy. And in Henoch-Schönlein purpura, that child which I showed you, a child with multiple purpuric spots on the skin, they may present with kidney disease, and when we do a biopsy, this is what we see. Okay, it is a kind of IgA. The IgA will be a lot of deposition in the mesenterium, and we, based on the clinical features, we diagnose it as Henoch-Schönlein purpura. Okay, so but IgA nephropathy is a different disease, but it may present within a Henoch-Schönlein purpura. That is in the pediatrics, they may ask you a question. Chronic glomerulonephritis, we don't usually ask you a question, but if there is an objective question, this is what they will ask. Give you a picture of symmetrically granular contracted kidney. Okay, so these kidneys, you can see they are bilateral, symmetrical, and granular contracted kidney. This is chronic glomerulonephritis. Remember these words because in chronic pyelonephritis, it is asymmetrical. Okay, chronic glomerulonephritis means the primary disease is from the glomerulus. In chronic pyelonephritis, the primary disease is within the tubules. Okay, so in that you get huge scars on the cortex of the kidney and it is asymmetrical. Okay, so that's why this word is very important. So this, I will share this, what I'll do is, because I don't have much time, I will share this PPT with you, okay, and just answer these questions on your own. I'm sure you'll be able to answer. You can go through these questions, okay, and each of those analytical questions, maybe you can answer on your own. And I hate checking those assignments on the thing. It takes a long time, but maybe I can't help it. Okay, so you can probably send these questions. This was RPGN. This is important because you can see as soon as you look at this, this is the malar rash, and this is full house immunofluorescence. That means IgA, G, C1q, C3, all of them are positive. This is known as full house immunofluorescence, which is seen in lupus nephritis. And in lupus nephritis, the light microscopy may occur as anything, but in this case, the basement membrane is extremely thick, and these are known as wire loops. These are wire loop lesions which are seen in lupus nephritis. This is again Henoch-Schönlein purpura. Diabetic nephropathy can come as a question for you, and we may ask you morphologic changes in the glomeruli, so you have to know these features. Okay, this is a diabetic nephropathy in which this is a hyaline arteriolosclerosis. This is the glomerulus here, and these are nodular glomerulosclerosis, which are also known as KW lesions or Kimmel-Still-Wilson lesions. Okay, so this is another question in pathology. We do ask you short notes on diabetic nephropathy. You have to know that what I told you, these morphologic changes, you have to know these. Okay, and this can come as an objective question, KW lesion. Amyloidosis, the most important thing about amyloidosis is that you can get this on light microscopy, you get this pinkish material which is orange on, or this is known as salmon pink color on Congo red stain, and on polarizing microscope you get this apple green bifurcations. So this is another objective question for you. This is a picture which we show you in the practicals actually. This is a microscopy in which if you remember your thyroid histology, there are follicles with colloid, right? So this is a kidney, and you're looking at the tubules filled with this pink material. It resembles the thyroid. That is why we call it thyroidization of the tubules. Okay, the tubule atrophy is there. There is fibrosis of the interstitium. All these are features of chronic pyelonephritis. This is a picture. Why I've put only this picture? It's because in the practicals, we show you a slide of this in which there is thyroidization, but you have to understand that this is a kidney because of the other features. It's not thyroid. Okay, Then benign nephrosclerosis also, we don't ask you questions, but objective type questions can come. That leathery, grain leather appearance of the kidney. This is the grain leather. Okay. And on microscopy, the arterioles undergo hyaline arteriolosclerosis. Malignant hypertension, there is pinpoint petechial hemorrhages on this surface of the kidney. This is known as flea-bitten appearance. And on microscopy, there is onion skin lesion or hyperplastic arteriolystic. Polycystic kidney disease, we don't usually ask, but it is important for you. In NEET, it is definitely important. Autosomal dominant and autosomal recessive, we have to know the difference between this. The gross difference is in autosomal dominant, you get big cysts like this. In autosomal recessive, you get these elongated cystic things, not huge. This is the cut section of the dominant. You can see big holes, but here you can see they are elongated holes. Okay, so thank you.